Good day, everyone. Welcome to our webinar today. Today, our topic is on the art and science of TIVA. Can it replace inhalational anesthesia? Perhaps because I'm severely biased towards using TIVA and TCI in my practice, that's why I guess I'm asked to organize this webinar. My name is Vivian Yuan. I work in Hong Kong at the Hong Kong Children's Hospital. I'm a pediatric anesthesiologist with interest in use of TIVA, TCI, and desmoid in children. I hope for those who want to learn more about TIVA in children, you will find this webinar helpful. And for those who use volatile as your default mode of anesthesia in children and in adults, you will start to explore and use more TIVA in your practice. I'm glad that we have Dr. Josephine Tang as our moderator today. She's a senior pediatric anesthesiologist who works at the KK Women's and Children's Hospital in Singapore, and her interest is on safety in anesthesia, training, and airway management. She is also our current ASPA president. Our other moderator is Dr. Kunza Wangmo from Bhutan. She's a consultant anesthesiologist with special interest in pediatric anesthesia. I will pass the time to Joe. Thank you, Joe.
Hello, everybody. Welcome to our webinar on TIVA in children. Let me first introduce the program for today. There will be two parts to today's program. The first part will be 3 lectures, first by Dr. Vivian Yuan, then followed by Dr. Grace Tang and Dr. Candice Lau, after which there will be a short question and answer session. And then following that, the part 2. Part 2 will be based on case discussion. The first case will be presented by Dr. Vivian Yuan on TIVA in children with challenging airway, and then followed by a short Q&A. And the second case discussion, it will be led by Dr. Teo Shu Ching. Topic is on TIVA in neonate, after which there will be a short Q&A session before we close and conclude for the day. So before we start the webinar, I will just quickly run through some housekeeping rules. If you have a question, do send in your comments and questions via the Q&A section. The chat and the raise hand functions have been disabled. Our moderators, myself and Dr. Quenza, will highlight your questions or your comments to the appropriate speaker during the panel discussion. Some questions will be answered by text with from the appropriate speaker in the Q&A section. The certificate of attendance will be automatically generated and forwarded to those who have submitted the post-webinar survey. Answers to the post-webinar survey will also be emailed to you. The post-webinar survey will be forwarded tomorrow at 5 o'clock Singapore time through email. Please ensure that you have correctly keyed in your full name and email address. Do not worry if you cannot stay through the webinar. The recorded version of the webinar will be made available on our ASPA website, on our Facebook, as well as YouTube. And polling, when a poll is launched during the talks, you will be prompted to answer the polling questions. You have 30 seconds to respond and submit your answer. We will then share the results soon after we end the poll. After the results is shared, you may close the poll so that you can see the slides shared by our speakers. And finally, a disclaimer. Please note that the information presented in this presentation is intended for educational purposes only and is not meant to be a substitute or for professional medical advice, diagnosis, or treatment. The views expressed in this presentation are those of the presenter and do not necessarily reflect the opinions or policies of any institutions or organizations with which they are affiliated. Additionally, the information presented may not be applicable to all individuals or situations. So before we start the webinar proper, together with my co-moderator, Dr. Quenza, we would like first to share the results of the pre-webinar survey that was sent out. The first question was, do you use TIVA in adults? And I think most of the respondents have answered only sometimes. The second question, do you use TIVA in pediatrics? Likewise, the majority, I think, also answered only sometimes they use TIVA in children. The third question, TIVA is more expensive than volatile agents in my country. I think most of the majority of the answer is yes, and quite a number of people do not know, and some people also say no. The fourth question, do you agree with the following statement? The depth of anesthesia monitoring should always be used with TIVA when equipment is available. And I think the majority who responded agree with this statement. Quenza will share the rest of the answers of the webinar, of the pre-webinar survey.
So when asked, most of the respondents disagreed that TIVA is associated with more airway events when compared to inhalation agents, while 12% agreed and 13% had no idea. 67% disagreed that TIVA in pediatrics is more suitable for long cases as it delays awakening in short cases, while 23% agreed and 19% had no idea. Similarly, 71% disagreed that TIVA should not be used in patients with critical airway, while 20% agreed and 9% had no idea. So 80% disagreed that TCI propofol anesthesia is dangerous in children, while 16% had no idea and 4% agreed. Okay, so the next talk is by Dr.
Everyone. Thank you for having us in this webinar. The first talk is on the basics of TIVA and TCI in children and infants. I have no financial disclosure. And there are two national surveys of the use of TIVA in children in United Kingdom and Ireland. This first survey was done in 2008, and the second one was done in 2018. So both of the survey has revealed that TIVA is an unpopular or non-default mode of anesthesia for most anesthetists, although we do see an increasing trend of using TIVA in children in United Kingdom and Ireland. And the most common reason for not using TIVA in children is because it's too fiddly or too troublesome. Nevertheless, even if it is difficult to use in children, TIVA is sometimes necessary when you have a patient with malignant hypothermia, when you work at outside locations, when you have to facilitate IOM in neurosurgery and spine surgery, or in airway procedure. And there are, of course, other benefits of TIVA, which we are going to discuss in our subsequent talks. Pharmacokinetic models are developed to show the blood concentrations after a drug dose. And the three-compartment models is the most commonly used model to describe the pharmacokinetics of intravenous anesthetic. The change in plasma concentration after an intravenous bolus can be explained by distribution of drug between a central and peripheral compartments. The speed of movement of drug between the compartments can be described by equilibration rate constant between the compartment, which can be demonstrated by this hydronic model. The central compartment is the compartment that connects to the effect site, and it is where the drug is metabolized and eliminated. It connects to the other two peripheral compartments, which has no direct connection with the effect site. It is observed that there is always a delay in effect after an effective drug concentration in the central compartment is achieved. An effect compartment can be constructed and a blood effect equilibration rate constant, the KEO, can be used to describe the delay in clinical effects. A model describes drug concentration versus time is a PK model, whereas a model describes effect and concentration is a PD model. With the statistical modeling technique, we combine the two together and it's a PK-PD model where we can use in clinical practice. Target control infusion system work the reverse way by using the PK model to calculate the drug dose. Accuracy can be assessed by how well the target and measure blood concentration match. Bias and precision are the parameters where we use in measurement of accuracy of target control infusion models. This diagram illustrates on the left-hand side that is a model of less bias comparing to the model of the right on the right-hand side, where it is significantly biased because most of the estimated value is smaller than the actual measured value. And this diagram also illustrates a model with good precision on the left-hand side and a model with not so good precision on the right-hand side. So how are children different from adults in terms of pharmacokinetics of propofol? Children have higher water content, and as a result, they have larger central compartment. They have larger volume of distribution. And the larger volume of distribution is associated with higher loading dose and higher maintenance infusion rates. Propofol clearance mature rapidly in the first 6 months of life. Induction, and as a result of the higher plasma clearance for the young children, that has also contributed to a higher maintenance dose required in young children. And this is also associated with longer context-sensitive half-time in children. With our knowledge in pharmacokinetics, we have published propofol infusion regimen for children of different age group. And this is a paper with propofol infusion regimen developed from a much larger data set where you can use for children under 3 years of age. If you have target control infusion pump, it is a lot more intuitive to give total intravenous anesthesia through a TCI system. In this study, we have demonstrated that the use of target control infusion system is associated with tighter or better control of level of anesthesia in children. The two most commonly used models in children are the Kataria model and the Pitt-Filzer model. Kataria model is a model you can use down to the age of 3 and body weight of 15 kilo. The covariates included in this model include body weight and age. Pitt-Filzer model is a model that has body weight as the only covariate, and you can use this model in children down to the age of 1 and body weight of 5 kilo. Recently, the Elevate model has become available in some of our infusion pump, and it is a model that was developed from a much larger data set, and it covers patients from the age of 0 to 88 years of age, and it is also a model validated for patients with obesity. And the covariate included in this model includes body weight, age, gender, and patient's physical status. On this paper, the performance of various models was evaluated in healthy young pediatric population. And surprisingly, a lot of the model they evaluated showed good performance in children. And when the simulation was done on a 10 kilo 1-year-old patient, the parameter estimated from the Kataria model and Pitt-Filzer model are in fact quite similar. And there are also differences in terms of pharmacodynamics. of propofol between adult and children. Often, children require higher plasma concentration to achieve the same level of anesthesia. And in this paper, it has shown that the younger the children, the higher the CE50 and CE95 of propofol concentration required to maintain anesthesia. When propofol was used as a sedation agent in children undergoing radiotherapy, the target concentration for induction and maintenance was 5.3 and 4.2 respectively. In the end, there is definitely a large inter-individual variability in propofol requirement to achieve anesthesia. Nevertheless, the level associated with loss of consciousness often correlates well with return of consciousness. And after all, most clinical scenarios are not tested, so most TCI models are inaccurate on your patient. So what do? I think titration and vigilance would be the key to safe TIVA in children. Thank you.
Thank you, Dr. Vivian. Thank you for your very interesting talk. If you have any questions for Dr. Vivian, please drop it in the Q&A box. Now, the next speaker is Dr. Grace Tang. She is an associate consultant with the Hong Kong Children's Hospital with a special interest in pediatric anesthesia. Over to you, Dr. Grace.
I will now go on to talk about practical tips on practicing safe TIVA in pediatrics. In our preparation regarding the equipment, we will need the following items. First of all, a propofol syringe with luer lock. Secondly, we need extension tubing to connect the syringe to the patient. Thirdly, we need propofol compatible three-way. There were case reports that showed with conventional three-way and prolonged propofol infusion, cracks would develop, which subsequently resulted in propofol leakage and patient awareness. Propofol three-ways are especially designed to minimize such cracks and leaks. Fourthly, we will need anti-reflux valves to ensure unidirectional flow to the patient. Bear in mind that the anti-reflux valves may appear very similar to needleless valves. However, needleless valves does not prevent backflow and is therefore not suitable. Lastly, we will need a syringe pump, ideally with target-controlled infusion model installed. Before connecting to the patient, we should make sure the TCI pump is connected to the AC power and that the battery is adequately charged. This is to minimize interruptions in drug delivery during the operation. Then load the syringe pump securely to the TCI pump. Perform a final check. Make sure we have the correct patient data, the correct syringe size, the correct drug, correct dilution, especially if remifentanil is used, and choose the correct model. When we connect the extension to the patient, we should also make sure that the IV cannula is patent and that the dead space is minimized. There should be a minimal number of three-ways used. Ideally, the infusion should be run on a dedicated infusion line. We should also avoid mixing drugs in the same syringe. Although we are aware that some anesthesiologists mix ketamine, remifentanil, or even remifentanil into the propofol syringe. However, we do not recommend that because it complicates the pharmacokinetics and makes it very difficult to titrate. There are also studies that show that when remifentanil is mixed with propofol at certain concentrations, the remifentanil actually breaks down more easily. Other than that, we should avoid putting excessive amount of three-way. The dead space is the distance from the propofol to the patient, and we will also need to minimize that dead space as much as possible. Intraoperatively, we should also position the patient so that the IV cannula is clearly visible and can be easily accessed. When we regularly scan for the vital signs and also the ventilator, we should also scan the TCI delivery system to ensure that the pump is running and there is no obvious disconnection. If the patient requires an unexpectedly high dose of TCI, always inspect the IV cannula. Watch out for subcutaneous swelling, any disconnections, obstructions that suggest that the propofol is actually not given to the patient. We advise for either processed EEG or raw EEG monitoring intraoperatively, in particularly when muscle relaxants are used. The advantage is that it allows easy titration of the level of propofol required, and it avoids keeping the patient too light and also avoids keeping the patient too deep, which results in burst suppression. We should avoid restarting the TCI propofol at all costs. In restarting the TCI, the amount of propofol that was given to the patient would not be taken into account. So the TCI model again delivers a high initial dose. Both the plasma and effect site concentration displayed on the syringe pump will not be accurate, and it does not reflect the real plasma and effect site concentration in the patient. In the same token, when we need to give the patient any propofol boluses for whatever reason, we should give via the pump. So what if we do not have a TCI pump? In fact, it is still possible to give TIVA manually. This is a recommendation by the McFarlane and also the Stewart group. So we can see that from the McFarlane's recommendation for children aged 3 to 11 years old, we can start off with 15 mg per kilo per hour and maintain that for 15 minutes. And for the next 15 minutes, we will decrease the rate to 13 mg per kilo per hour and so on. That way, we can still give TIVA. There are also educational websites or applications online that run simulations according to the Pediatric, Cataria, and Elevad model. Here we use the SimTIVA app as an example, and the QR code is displayed on the right. So when we click into the page, it will ask us about the demographics of the patient. After we put in the correct patient info and read in disclaimer, we can proceed to choosing the CP model, and that is what we are trying to simulate. Then we put in the CP that we want to target, and in the preview box above, we see that it teaches us to give a bolus of 15 mg and then infuse at 16.5 mils per hour. After pressing start, it will display a graph that shows us what the CP and also the CE level is. On the right side, it will also show us when to change the infusion rate. So we see that in 10 minutes, we'll decrease the infusion rate to 14 mils per hour. And at 18 minutes, we'll decrease the infusion further to 12 mils per hour, and so on. What to do if the pump suddenly stopped? Well, that is definitely not the end of the world, and there are several ways to go around with it. Firstly, if the patient is already at steady state, we can restart the TCI pump in a manual mode using the rates that is exhibited on the device display just before the power failure. We can also consider referencing from the SimTIVA app. So here we have a graph, and we see that, for example, at 19 minutes, the power suddenly stopped. And we can actually scroll the cursor at 19 minutes to see what the infusion rate was, and it is at 12 mils per hour. Alternatively, if we restart the TCI model, start incrementally. The device will be naive to the drug already present at the effect site. Therefore, a bolus dose will be given, and the CECP calculations will not be accurate. In this case, we strongly advise to titrate against the EEG. Lastly, we can consider changing to a volatile-based technique. Bear in mind that there may be potential exaggerated hemodynamic response due to synergism between the propofol remifentanil and the volatile effect site. So here are the references, and that's the end of our presentation. Thank you very much.
Thank you, Dr. Grace, for the many practical tips, very useful. Now the next speaker is Dr. Candice Lau, and she is a consultant anesthesiologist with the Department of Anesthesia and Perioperative Medicine, Hong Kong Children's Hospital. She's also an honorary clinical associate professor with the Department of Anesthesiology, School of Clinical Medicine, Hong Kong University. She has special interest in pediatric cardiac anesthesia and patient blood management, and also special interest in the use of TIVA in patients with congenital heart disease. Over to you, Dr. Candice.
Hello, I'm Candice from Hong Kong Children's Hospital. Today, I will discuss about the use of TIVA in ambulatory surgery on pediatric patients. I have nothing to disclose. TIVA is known to reduce the incidence of reactive airway, post-op nausea, vomiting, and emergency delirium in pediatric patients. Let me show you a few slides to refresh our memory. The APRICOT study done over 260 hospitals in Europe showed that the respiratory critical events is reduced when compared using with inhalational technique. Another study for comparing the use of TIVA with inhalational isoflurane for patients undergoing MRI have similar result. TIVA can decrease the laryngeal spasm, cough, hiccup, and other airway events. A meta-analysis showed that the TIVA, when compared to inhalational agent, can decrease the post-op nausea vomiting in 3.5 folds in adults and 5.7 folds in children. And the latest guideline of consensus guideline for management post-op nausea vomiting suggests that the use of propofol for induction and maintenance as class A1 evidence, while the avoidance of nitrous oxide at volatile at class A1 and A2 evidence. Multiple studies to compare the use of TIVA and the inhalational technique have already demonstrated the TIVA technique is effective to decrease the incidence of emergency delirium. Now I will discuss about some controversy issue. So the first scenario will be if we want to keep the patient on spontaneous ventilation in the ambulatory surgery, will you choose TIVA or will you choose inhalational technique? Maybe we can do an example. A 4-year-old boy come for circumcision today, and will you choose TIVA technique or will you choose inhalational technique? Can you please make a vote? Okay, now it seems that 50% of our audience think they will use TIVA, and while the 48% of the audience will use sevoflurane. Okay, we can continue. Okay, let's continue to my presentation. Spontaneous ventilation is already a well-established technique for pediatric patients undergoing airway procedure. So in Pediatric Anesthesia 2010, the author has suggested the TIVA and spontaneous respiration is effective technique to manage anesthesia for airway endoscopy and surgery in children. And this is a study for strabismus surgery. This is a non-airway operation, and 45 kids, they are using the TIVA and remifentanil infusion. And the author concluded younger children, especially those aged less than 3 years old, can tolerate a higher dose of remifentanil while still maintaining spontaneous respiration. So TIVA with spontaneous ventilation is readily achieved in younger children and infants. In our hospital, we will use perfusor or LUS if the patient is less than 1 year old. And after starting the gas induction, and we will establish our intravenous cannula and start our TCI program. And at this moment, we will keep the plasma concentration between 4 to 6 mic per mil, and then we will insert the LMA. Patients sometimes will be apneic at this moment, so we'll transiently support the patient breathing with ventilator. Because we would like patient to return to spontaneous ventilation, remifentanil will not be used. But we will use the adjunct. Most commonly will be fentanyl, desmetromethine, or regional block to decrease the dosage of propofol during the intraoperative period. And during the surgical incision, we need to transiently increase the plasma concentration or give a bolus analgesia to ensure there is adequate depth of anesthesia and analgesia. Otherwise, the patient will move and the surgeon will complain. So at this stage, usually because of the stimulation, patient will return their spontaneous breathing. And we can slowly titrate the plasma concentration according to the clinical effect. Usually can keep around 3 to 4 mics per mil with good regional block and use of adjunct. At the end of operation, you can slowly decrease the plasma concentration, but keep it more than 2.5 mic per mil until the nurse do the dressing. We will stop all the infusion, flush the cannula to ensure no residual drug. At this moment, you can remove the LMA, transfer the patient to trolley. Patient will usually be mildly sedated and very comfortable when transferred to the recovery. And this is the data from my hospital. The blue bar is the case of day surgery. You can find that in my hospital, almost 86% of the day surgery patient, they receive TIVA technique. So the second scenario will be the comparing the expenditure on the anesthetic drug. Do you think TIVA will be more expensive or inhalational gas will be more expensive? So in this scenario, we just comparing the drug cost. So the TIVA will be the propofol cost plus or minus remifentanil. And for inhalational technique, we'll choose the sevoflurane. Can you make a vote now? So in this question, 45% of the audience will think TIVA with propofol will be more expensive, and 43% audience think inhalational will be more expensive, and the remaining 12 have no idea. Okay, let's continue to my presentation. So the first case is a laparoscopic hernia repair patient with positive pressure ventilation. First patient, patient A, received the gas induction and maintenance. At the end of operation, a bolus of propofol was given to decrease the incidence of emergency delirium. While for patient B, sevoflurane was used during the induction and used TCI to maintain the anesthesia. Because we would like to keep the patient in a positive pressure ventilation, so remifentanil was used as an adjunct. For all the other drugs, it's just the same for both patients. This is the cost of the drug in Hong Kong, and you can find that sevoflurane is cost more than $1,200 per bottle, while propofol and remifentanil is quite affordable. For patient A, use gas for the whole process, it costs more than 200 Hong Kong dollars. While for patient B with sevoflurane for gas induction and with 2 ampoules of propofol and 1 vial for remifentanil, we won't share the remifentanil in our patient. It costs around $134. So for patient B, there is a 38% cost reduction. Second case is a circumcision, and this time we would like to maintain spontaneous ventilation for the patient. For patient A, again, use sevoflurane for induction and maintenance, and at the end of operation, use propofol. For patient B, use a sevoflurane of gas induction and then TCI, and both of them have received a penile nerve block. So this is the cost of the drug. For patient A, it costs more than $200. And for patient B, because remifentanil is not used to maintain the spontaneous ventilation, you can see that the total cost is only $40. So there is a 78% cost reduction. TIVA is not just only cost saving, but is reduce any unplanned admission due to post-op nausea, vomiting, and emergency delirium. Can further save the cost of unplanned admission. In our hospital, you can find that only 25% of our case will be done under inhalation, but the money we use to buy the inhalational gas is almost 4 times of that of used to purchase the propofol. So there is a 370% increase for the expenditure on the sevoflurane. So we're going to the last discussion. In a high-risk patient, we define an ASA equal or more than 3, come for ambulatory surgery or some day procedure. Will you prefer use TIVA technique or use inhalational technique? Can you please vote now? Okay, here is the result, and it's a 50-50%. Half of the audience think they will use TIVA, and half of the audience will use inhalational gas. Now we continue to our presentation. This is the data from my hospital. In my hospital, the ASA3 patient, half of them receive TIVA technique and half of them receive inhalational technique for all the operation. And for ASA4 patient, you can find that some anesthetists will still prefer the use of TCI technique. Although the inhalational technique, there will be more anesthetists will choose this as a first choice. So in my hospital, TIVA is the choice for our anesthetists in around 50% of the high-risk patient. So how about TIVA patient receiving TIVA technique is high risk and at the same time for ambulatory procedure? So from my hospital data, there are 27% of the patient, they have received TIVA with or without agent, mostly is dexmedetomidine. How about for the remaining 70% patient? That 70% of patients, they also rarely use sevoflurane. The most common technique is the infusion of the dexmedetomidine plus or minus other agent, including ketamine, midazolam. In the high-risk patient, we are worried about the propofol infusion syndrome, but it is less likely if just give in a short duration of infusion. And another worrying thing is the myocardial depressant effect and vasodilatory effect, which can lead to low cardiac output. There is no much literature I can find to compare the use of TIVA versus the inhalational technique in high-risk patient. This is an Egyptian study to compare the use of ketofol, the propofol with ketamine versus the use of sevoflurane in pediatric cardiac cath patient. The patient mostly are ASA 2 or 3. And the author conclude that both the anesthesia technique is feasible, but the propofol ketamine combination have a advantage on reduce the agitation and post-op nausea vomiting when compared to the inhalational group. To use TIVA or not in an ambulatory surgery is dependent on multiple factors. First, whether the patient will be beneficial because TIVA is known to decrease post-op nausea, vomiting, emergency delirium, and also the airway event. So it is favorable in ambulatory surgery. And if your drug is quite affordable and also the equipment is readily available, they will also increase your intention to perform TIVA on your pediatric patient. Last but not the least, knowledge is very important. If the anesthetists have to choose one technique, if they have more knowledge to back up themselves, they get more familiar with this technique and know the advantage and disadvantage. So they will have more intention to use these techniques on the patient. This is the end of my presentation. I wish I can give you a better picture on the use of TIVA in the ambulatory surgery for our pediatric patient. I welcome the question from the audience. Thank you very much.
Thank you very much, Candice, for your talk. Now we open the first Q&A session. There are a few questions in the Q&A. The first question would be, I think it's addressed to Grace regarding manual titrations if we do not have a TIVA pump.
Right. If we do not have a TIVA pump, I can think of two ways to maneuver around that. First of all, is to go according to the McFarland recommendations. So they have a clear recommendation on how to give manual infusions. For example, start by 15 mils per kilo per hour in the first 15 minutes, and then decrease it at a certain time. Another method would be to use the simulation app, the SimTIVA. That was on the in that simulation, just type in all the patient's demographics, and then it will show a graph, and then they have a step-by-step instruction on when to give a bolus and what the starting infusion is, and then when to change the infusion rate. So I think that would be a good method to give the TIVA without TCI pump.
Thanks, Grace. I think there are other comments in the Q&A about the cost besides the drug in TIVA, the consumables, especially the one-way valves when using TIVA, and also BIS. Have you considered these costs when you're calculating between the use of inhalational and TIVA?
Thanks for the question. As I've mentioned, I just would like to just compare the cost. So I just figure to propofol Remy versus the cost of sevoflurane, because actually, if the patient is maintaining spontaneous ventilation in our hospital, we seldom apply this on the patient, because if the patient moves, which is the best manifestation of inadequate depth of anesthesia. So if we maintain on spontaneous ventilation, avoid the use of muscle relaxant, and your patient move, then that means it's not in the TIVA is the plasma concentration for the patient is not high enough, so I just increase it. So we rarely apply the BIS for patient in spontaneous ventilation. So if we use muscle relaxant and also use TIVA technique, and probably if you want to apply the BIS in the older patient, we will use it, but in a smaller one, I'm also not very rarely apply the BIS. And also for the other course, if you mentioned about, okay, if you have used sevoflurane, I have a very powerful anesthetic machine with no flow anesthesia, that will be a huge cost. Maybe that anesthetic machine maybe cost quite a lot. So how about comparing the pump, the other consumable, then that would be quite a big debate. So I would just like to restrict it to the drug of the cost.
Maybe I have a comment on the cost as well. I'm an advocate for monitoring depth of anesthesia anyway, so I will encourage everyone to use, but of course we have to consider the cost. In our institute, recently we have some BIS sensor which is not expensive. And also we have monitoring by raw EEG, which is also not expensive. So if you explore, there are other ways to monitor the brain, which I think we should do as far as possible. And in terms of consumable, they are actually quite cheap comparing to the drug. So I think there is a paper published or a letter published comparing the cost, considering the consumable like the syringe and the 3 ways, and in the end, is still not as expensive as inhalation anesthesia. And there is a question on the gas flow. So of course, if you have very low gas flow, you save inhalation agents, so you save on the cost. However, reflecting from our department drug budgets, like we have about 20-something% proportion of inhalation use, and close to 70% of propofol use for anesthesia. And then the cost of sevoflurane is still on the top comparing to propofol. So, so that's some facts I can share with everyone. Of course, the cost of drug can vary between countries.
Thanks, Vivian, for your comments. There is a question on patients with suspected allergy to eggs. Would you still use TIVA propofol in these patients?
Yes, I don't know if other speakers want to share. Maybe Shu-Ching can talk.
I do use as well, but of course I will make sure that what kind of reaction does the patient develop if she was if the patient has taken an egg. If it's kind of like anaphylaxis reaction, then of course I would, whatever it is, I would try to stay as far as possible from propofol. But or else I have used it in patients who have suspected allergies to egg as well, and so far, touch wood, that everything seems to be okay.
Yeah, same here.
I think we have time for one more question. Does pre-medication and benzodiazepine with or without opiate, with and without atropine prior to TIVA with propofol affect the depth of anesthesia? How would you go about it? Do you still start at 15 mics per kilo or wait 15 minutes to titrate it? Would Grace like to answer this question?
Okay. Benzodiazepines without opioids. That is actually a very good question, because from the model, they only consider using one medication. So the added effects, the synergistic effects with opioids and benzodiazepines, that has to be studied. And in fact, I've talked to the developer of the SimTIVA app. He is on the way of developing another model that studies whether there's any drug interactions between using opioids and also using TIVA at the same time. So for the time being, I do not have a very good answer. I would think, yeah. Do I start with 15? That is a very good question. I would follow, if we're using the Macfarlane's equation, I would follow that. And then I would also follow the TCI propofol pump as well. Would anyone else have another comment from the panel?
I think we are down to our last 1 minute.
If there are no other questions, we will close the first Q&A session and move on. So our next speaker is Vivian, Dr. Vivian Yuan. She is the Chief of Service for the Department of Anesthesia and Perioperative Medicine in Hong Kong Children's Hospital. And her talk in this part 2 will be focused around a case on TIVA use in difficult airway. Let us welcome Dr. Vivian.
Good day again. In this case-based discussion, we are going to go through a neonate with difficult airway. This is a newborn with Pierre-Robin sequence airway features, including micronasia, glossoptosis, submucosal cleft palate, laryngomalacia, and severe congenital subglottic stenosis. At birth, weighing 3 kg at 40 weeks, he was found in respiratory distress, and it was unable to intubate the neonate with a 3.5 or size 3 endotracheal tube. He was maintained on high flow nasal oxygen with a FiO2 of 21% with good oxygen level. Subsequent CT revealed severe stenosis at the cricotracheal junction. Our ENT surgeon booked an emergency balloon dilatation under rigid bronchoscopy, plus or minus anterior cricoid split, and steroid injection. And we are lucky to go through all these procedures. We also plan to do an open hernia repair. In summary, this is a neonate in respiratory distress with Pierre-Robin sequence airway and tracheal stenosis. What anesthetic technique would you use for maintenance and infusion, maintenance and induction? Sevoflurane-based anesthesia, propofol anesthesia with remifentanil, or desmedetomidine with ketamine. An ideal technique would be a technique that allows us to maintain adequate oxygenation and ventilation. And it is also ideal to allow spontaneous ventilation with an unobstructed surgical access so that the surgical colleague can evaluate the dynamic airway function and airway obstruction. We want a stable surgical condition with no laryngeal spasm and no interruption. And we also want the delivery of anesthesia to be independent of the airway so that you can adjust and titrate the depth of anesthesia as required. Of course, we want no pollution from anesthesia and rapid emergence. Sevoflurane anesthesia is associated with some of the features of this ideal technique. However, sevoflurane anesthesia is associated with higher risk of laryngeal spasm and airway reactivity when it is compared to propofol. Moreover, delivery of inhalation anesthesia is not independent of an airway. Nevertheless, do you worry about propofol cause apnea in this neonate or in children? Yes, absolutely. It depends, or I have no idea. Okay, seems quite a lot of people think it depends on how you use it. Let's continue with the talk. I would say it depends. because it really depends on how you deliver propofol. As Grace has suggested us to visit this website or application on the internet, which is free of charge. And it is illustrated on this two diagram that different method of administration of propofol results in different initial plasma concentration. With target control infusion, you will be able to achieve anesthesia in a slower fashion, a more gentle manner. So that's why with control infusion, you would be able to avoid apnea even in this neonate. And you can go and play around on this app to appreciate how different mode of administration cause different change in plasma concentration with propofol on this application. And during anesthesia with a patient in spontaneous breathing under TIVA, how do I gauge the depth of anesthesia? Usually when the kids are deep enough, they would have decreased in respiratory effort and their breathing become regular. They will allow you to intervene, perform direct laryngoscopy for topicalization of the airway without reacting or complaining. So usually I would do the DL to give the LA, and if the patient allow me to do the direct laryngoscopy and I don't hear a raising heart rate with the intervention, I would be able to pass the patient to the surgeon for surgical intervention and examination. And during the procedure, we do not have capnography. How do we monitor patients' breathing? One easy way would be to look at the surgical field, because you will appreciate patients' breathing effort by observing movement of the vocal cord. You can also appreciate patients' breathing effort by placing your hands on patient's abdomen. We go back to this case. So this patient has a 24 intravenous cannula in situ. What I did for this patient was I load the patient with dexmedetomidine at 1 mic per kilo, followed by an infusion at about 1 mic per kilo per hour. Then I start remifentanil at 0.05 mic per kilo per minute, and I titrate the propofol infusion using target control infusion system and elevate model. And the target control level range from 2.5 to 5.5 grams per ml throughout the procedure, depending on the surgical stimulation. Of course, I apply topical anesthesia to the airway. The first attempt of balloon dilatation, the surgeon felt that the result was suboptimal. Therefore, anterior cricoid split was performed in order to dilate the airway further. After second balloon dilatation, surgeons attempt to intubate the neonate with a 3.5 endotracheal tube. However, the endotracheal tube entered the force tract created during the anterior cricoid split. And we encountered difficulty in ventilation after intubation. There was no end-tidal CO2. And patients started to desaturate down to around 80%. We immediately removed the endotracheal tube. The patient was breathing throughout this instant. So after oxygenation with a face mask, the oxygen level improved and the SpO2 was back to 90%, 99%. And when the patient was breathing spontaneously, we allowed the surgeon to use a fiber optic bronchoscope to reintubate the patient and adjust the endotracheal tube in a position where it does not go into the force tract created. So in summary, what I wanted to illustrate was with the use of TIVA anesthesia, especially target control infusion, you may be able to achieve stable, steady level of anesthesia in young children, in infant and in neonate, even in children with difficult airway. Slow induction and titration would be the key. I welcome questions after this. Thank you very much for your attention.
Thank you, Vivian, for your talk. It's very interesting. Now we open the second Q&A section. Any questions for Vivian regarding this case discussion? Please, you could put it into the chat. Put it into the Q&A section. So Vivian, maybe I'll ask a question. Do you have any worries about hypotension or hemodynamic instability when you use propofol TIVA together with remifentanil and dexmedetomidine?
In my experience, usually in the initial part of the surgery, hemodynamic is not a problem. They are high stress, under a lot of stimulation, so they need quite a bit of drug, but you still have to titrate and see what the patient needs. But usually in the more stable and steady part of the surgery, they can become hypotensive. Sometimes I just have to give a bit of phenylephrine, but not for all cases.
When you add dexmedetomidine and remifentanil, would you then start with a lower plasma concentration for the propofol TIVA?
I always start low. So even though in our experience, they do need about at least 3, mostly 4 or 5 ml per ml to maintain adequate depth of anesthesia, but I still start at 2 or 2.5 ml and take the time for the patient to settle and see if I need more. Because I already have the dexmedetomidine on board, plus some remifentanil for the painful stimulation. So always titrate. When I have to do these cases without a TCI, it's the same principle. When I have to give a bolus of propofol to deepen or to induce anesthesia, I also give very small dose, like less than 0.5 milligram per kilo, titrate and see effect.
Thank you, Dr. Chris. There's another question from the audience. Is it possible to replace propofol to midazolam or rimidazolam? It would still be called TIVA.
Is it possible to
replace propofol with midazolam or remidazolam? It would still be called TIVA.
It's still called TIVA, but
yes.
I don't think midazolam have the same potency. And for remidazolam, I have no experience. We don't have this drug in our institute or in our country.
Thank you. There is another question. How fast do you load dexmedetomidine?
Well, I load it over 5 to 10 minutes. Depends if I have a patient who's very fragile, with other problem comorbidity, I probably lower it over 10 minutes, and probably the patient may not need 1 mic per kilo. Just this case, he had 1 mic per kilo, but I lower until the patient settle down, not complaining, not crying. Then I start the rest of the TIVA. So for some patient, they might just need 0.5 mic per kilo and they are settled, and then I can start induction with propofol and remifentanil. So
Thank you.
it's also, again, titration.
Thank you.
Thank you, Vivian. I think we've come to the end of our second Q&A section. We will move on to our last speaker, Dr. Teo Shuqing. Dr. Teo Shuqing is consultant at Pediatric Anesthesiologist and head of Department of Anesthesiology and Intensive Care in Sarawak General Hospital. Her interests are in pediatric TIVA and regional block. Her talk for us today is TIVA propofol use in neonates. Thank you, Dr. Ching, Dr. Teo.
Thank you, Dr. Joe, for the kind introduction. I shall move on to my TIVA in neonates case discussion. I don't have any disclosure. These presentation images are purely for educational purpose. We are constantly in the learning process to refine and improve our management in anesthetizing neonates, and I'm not expert in EEG interpretation. I have no affiliation with any companies as well. Okay, first off, to show that this elevated model is an effect set targeting, and this is the interface where we plugged in the effect site alert model, concentration of propofol. Minimum age is in terms of week or years, 1 week, but we do that in less than a week as well. Just keep it as 1 week. Minimum weight is 700 grams. Height, I don't think that it's a minimal that I can see. The next page is where we plugged in the gestational age, what age the child was born, and then the target is everything. So in this case, for the 700 grammer, the loading dose is 0.19 mils. Okay, so we will talk about this baby, which who is 27 weeker, 12 days old, 1.17 kilogram, diagnosed with duodenal stenosis, planned for duodenostomy. Now, he was already intubated and ventilated in NICU for respiratory distress syndrome, but prior to induction, he was alert and active. So we induced targeting effect site, propofol of 2 mics per mil, and Remi of 0.1 mic per kilogram per minute. Then we monitor with EEG, and then once we see that there's a lot of burst suppression or reduce in the EEG waveform, then we paralyze with atracurium 0.5 milligram per kilogram. So this is what it looks like for a 12 days old compared to an 8 months old. 8 months old, you see a lot more wavery EEG waveform, whereas in 12 days old, most of the time we see this flat EEG. Now, let's little blips here are most likely ECG artifact. So this is how it looks like on the spectrogram. So the white strips are artifact or motion. The contact is not so good. So this is how we struggled to put on the sensor on a little baby. So once the surgery has been started, the mid-incision made, then the propofol will be slowly titrated down until there's some appearance of EEG waveform at 0.1 to 0.2 mic per mil stepwise. Eventually, we maintain about 1.4 to 1.5 mics per mil, with remifentanil running at 0.1 to 0.2 mics per kilogram per minute. We gave morphine as analgesia post-op, but if the patient was not intubated from the beginning, I probably have employed regional anesthesia. So once the peritoneal layer is closed, we reverse and then reverse the muscle relaxant and further reduce the propofol slowly until last 1 to 2 stitches. Then we will turn off the remifentanil and propofol to establish spontaneous breathing. Of course, in this case, since the patient is ventilated post-op, there is no absolute necessity to actually bring up the spontaneous breathing. Now you may ask at what level of propofol is optimum for this age. I would say it's difficult to judge. We are all still in the learning process, so it's best to learn on non-paralyzed patient, as you know that it's very difficult to get an awake child to stay still. So if the anesthesia is lightened to a certain plane, then patient will start moving. So that that's the indication that you need to deepen the patient. And we also learn this EEG from what we are most used to, sevoflurane anesthesia. And based on that, then we use it, apply it in TIVA as well. So this is what it looks like when the abdomen is closed and turn off the propofol. There's some more waveform coming up, and this is when he opened eyes. So of course, I think this may be partly because of the movement as well. And you will see here, there's a lot of black strips with a blue dot at the bottom. So those were the periods of burst suppression. Okay, so this last two slides, so that was the case, and the last two slides, I'm just going to talk briefly about the pros and cons of TIVA in neonates. I think we all agree that TIVA is very good in airway assessment. It applies in neonates as well, especially when we have to do tracheoesophageal fistula repair. The initial bronchoscopy assessment for the fistula, it becomes very handy that you can still maintain patient on spontaneous breathing, and you won't have a problem with achieving the depth of anesthesia that you require to avoid any untoward events. The other condition that makes it quite necessary is when a child is ventilated on high frequency jet ventilation or oscillatory ventilation, where you have no way to provide inhalation agent. Well, at least in my center, there's no way to do it. So we have to use intravenous anesthesia. Traditionally, we use ketamine infusion or midomorphine, but now we know we have an option to run a propofol TCI. So of course, the downside of it is, you need additional line, and sometimes we encounter the tricky situations where the setting additional line is really, really difficult in the tiny ones. Then we will probably move away from TIVA. You also need a special tubing like this with minimal dead space. We usually use this T-connector in almost all our pediatric patients. Now, for this particular child, he is 1.7 kilogram. So the loading dose here is actually 0.33. Now, if I were to use this tubing, so it probably end up somewhere here and it won't reach the patient at all. Other things will be, of course, you need the pump with the model, and also we need lots of plasters to plaster the sensor strip to the forehead. I was asked also that, if there is no remifentanil, what other options do we have? Some people may say alfentanil, sulfentanil, but it's not available for us. So I don't have experience with those opioids, so I wouldn't give you any advice on that. Ketamine, not in a TCI, probably run as a mass infusion rate. To monitor with EEG, it will show you a different patterns, I presume, but anyhow, in neonates, most probably you still get inactive EEG. Okay, that's all for my case. Thank you.
Thank you, Su-Ching, for your very interesting talk about use of propofol TIVA in the neonate. If the audience has any questions, please key into the Q&A section now.
I think there's a question that someone is asking, did you load the remifentanil? The answer is no, we don't load remifentanil. The time that I would load remifentanil is if I need to apnea a patient for intubation, for example, then sometimes I do bolus it to achieve the apnea period.
So switching, are there any situations when you would not choose TIVA propofol in a neonate?
One that's if I don't have enough lines, IV lines. So it's advisable to use a dedicated line just to run the TIVA, or else whatever additional drugs or things that we give, we are inevitably giving a bolus of the drugs to the patient. So, but in situation where I can't get an additional line, then I choose to use inhalation. There's no absolute contraindication of using sevoflurane anyway. There's another question. Do you encounter hemodynamic instability with TIVA propofol? If I monitor with EEG, I notice that the chances of hemodynamic instability is less because we will be able to dial down our propofol. But without that monitoring, then I think most of the time we probably provided too much to our neonates. That's why we see a lot of hypotension. There's a question, why do you avoid caudal block? I don't. In fact, I would go with regional anesthesia whenever possible. But in the case that I illustrated, because the patient was already intubated and ventilated for respiratory distress syndrome, so then I would just continue with morphine that will help with the sedation as well.
Thank you. There is still one unanswered question. So the audience, one of the audience is asking the panelists, between the two rare adverse events of malignant hypothermia for SIVO and propofol-related infusion syndrome for propofol, which would you rather avoid?
Well, I will avoid both. So if there are patients at risk of PRIS, of course, then I use other technique. And of course, if there are patients at risk of MH, then I use TIVA. But if it's unpredictable, then it's unpredictable. I mean, there will be scenario where we don't know, then my preferred technique will be TIVA. I don't know about other panels.
Yeah, I agree with you. My preferred technique is also TIVA. Same like, if I know that there is an MH risk, then I'll absolutely go with TIVA. PRIS in intraoperative propofol infusion actually is very, very rare. In our part of the world, actually, MH it's more prevalent compared to PRIS. So we prefer to use TIVA.
Thank you.
How about Grace and Candice?
And for the propofol infusion syndrome, I said if in a short, just for a short procedure, and actually TIVA is rarely occurred, and so I think it still can be safe to use it, and we will. Of course, will be for the MH. There should be some genetic problem before. I mean, the patient should be have some susceptible genes. So it's very rarely. It is actually very rarely to predict it. So I think it's just happened. That is so unlucky. So you can't say that which one I would like to avoid.
Sharon wants to know, do you talk to parents about the very rare side effects such as dystonias prior to TCI? Anybody want to take this question?
In my practice, I don't know about Grace or switching or Candice.
I think also not talk about it, because just like if you even use gas inhalation, the patient will struggle, will have some funny movement. So if I also need to talk, I also rarely mention it to the parents. So it's I think it's I won't talk about this.
Yeah, same here. I have not talked to them about the very rare side effects.
We have one question from Dr. Obara from Japan. To all speakers, how do you think about the advantages of a combined intravenous volatile anesthesia as maintenance? Some, not many, think it may be advantageous compared to a single use of either TIVA or inhalational anesthetic in terms of PONV, time to extubation, movement during surgery, post-operative pain perception, and emergence delirium.
I think
Sure,
John Cho
you-
asked
yeah.
a research question.
Yeah.
So it can be our next research project, multi-center.
Yeah, but from what I observe, if it's a pure TIVA, then the emergence delirium will be less. But when we convert, our common practice is to gas-induced anesthetic line and then convert to TCI. The chances of emergence delirium is still there. And I haven't seen very, very bad emergence delirium with pure TIVA alone. So I think it's kind of, it can be unpredictable as well. But what we also want to bring across here, it's, the monitoring of the EEG and the BIS, and, it's quite important. So even if you use combined or single, our aim, it's not only so that patients are not aware, we also don't want to give too much to patients.
Dr. Jo, you're muted.
Thank you very much for everybody for answering all the questions. I think we have answered most of the questions in the Q&A section. So I think we've come to the end of our last Q&A section. I'd like to thank all the speakers and all those people who have participated in this webinar. And before we close, I would just like to again remind everybody that a certificate of attendance will be automatically generated and forwarded to those who have completed and submitted the post-webinar survey, which is a short quiz. And the post-webinar survey will be forwarded, emailed to you tomorrow at 5 o'clock Singapore time through, and the answers will follow as well. Please ensure that you have correctly keyed in your full name and email address. And also, if you would like to listen to this webinar again, the recordings of this webinar will be made available on our website, Facebook, and YouTube. And also stay tuned for our next webinar, which is going to happen on the 16th of April. And it will be on skill with simulation case-based learning. And also our ASPA conference will be happening in June this year, 16th to 18th June. So if you have not registered, please register. The date to note is 15th of April for early registration. And please also submit an abstract to the meeting. This is a preview of the program for the upcoming ASPA 2023 in Korea. The price is in US dollars. Please register whenever it's convenient. Registration will also include a dinner at the Vista Cibition Vista restaurant. And last but not least, ASPA is a non-profit organization. So if you are able to donate, do donate and help us in our cause. So before I end, I would just like to call Dr. Vivian to maybe summarize all the key points, key learning points for today's webinar.
Well, thank you, Joe, and thank you, team, for participating in this webinar. I hope all the participants has enjoyed the webinar today. We have discussed on some basic aspects of TIVA, and then use 3 cases to learn about TIVA. 2 of the 3 cases are quite extreme. Nevertheless, you can start using TIVA on general and less extreme situation, and I hope you have found this webinar useful. Thank you.
Thank you everybody for attending the webinar. Have a good weekend.